Yeah, good. ما في مايك ولا هذا بس؟ مرة اوكي. السلام عليكم again. كيف حالكم؟ All good? Shall we start عشان نخلص بدري؟ يلا. If I have to be fair and give you the same information I gave the females, but we invested more about sunscreens. أول question, how many of you put sunscreen? Only two? How many have put sunscreen in their life? Have put sunscreen in their life? Yeah. Yeah. How many have you tanned? يعني literally went to the beach and tanned. عادي ترى ما عشان dermatologist. Fine. تدري? Yeah. How many of you love tan? Be honest. Okay. So I have one question. Actually, and excuse me to ask this, يعني, and this is actually very important. Do we have to put sunscreen? Why? 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 Yeah? Cancer. Melanoma. Okay, you're smart. عشان lecture. What else? UV damage. I'm يعني خلينا نقول I'm not a physician. I don't know what that means. How would you say? Think simpler. Yeah, what does that mean? يعني how does that translate? Yeah, no, you're talking science. I want layman term.
It changes our DNA because
again, two science. I'll be like, oh, what DNA? What's DNA?
it stops the cells from dividing.
Get you. I'm a pharmacist. Yes, but I'm a pharmacist. How am I gonna sell it to you? This does one. Do you think that's the main reason in Saudi Arabia people buy sunscreens? Who has sisters or wives or anyone has sunscreens? Almost all of them do. What did you say? Burn. I wish that was the reason. You're close. Yes, pigmentation is the main reason here in Saudi Arabia people use sunscreen. But there's another reason. Photoaging, for preventing aging process, okay? So those are the main reasons. But which one of them, what are the three characteristics of sunscreens we have to have? What does SPF mean? Sun protection factor. Yeah, and when you say SPF 30, it means you're likely to burn 30 times less than without it. 45, 45. But the difference between 30 and 100 is basically 30 protects 94%, 100 protects 97%. So don't be fooled by the numbers. That's one. But we ask people to use higher because they don't use the recommended amount. I always tell people 2 fingers like this is enough for face and neck. Okay? That's 1. 2, what else other than SPF? Huh? No. Characteristic recommended choice of sunscreen. There's 3 elements. 1, SPF above 30. 2, that's, I know what you're saying. They are, sorry? No, that's just increasing the amount of it. Water resistant is actually 1. The third one, broad spectrum, UVA and UVB. Out of the rays that you get from the sun, what's the percentage or overall of UVA ultraviolet? Is it the majority or the minority? Sorry? It's very minute amount. What is the main rays that you get from the sun? No, we said ultraviolet altogether, UVA and B, right? Is minute. What's the rest? What are you doing? What is coming to you. It's true, it's a form of energy, but what is the rays called? It has a name, actually.
Ultraviolet.
No, we said UVA, UVB, right? And there's UVC. Do you know if we have UVC, what's going to happen? You will all get skin cancer. What protects UVC? Ozone layer. 3. النقطة اللي بقولها. When you look at the sun, do you see something? Would you see something? So visible light is the majority. And the problem with pigmentation, the majority happen from visible light. So you're giving a sunscreen that's protecting you from this. What about this? Yes, it does help with pigmentation, blah, blah. But the majority is from visible light. Definitely, you have to seek shade, wear clothes. Some even people use umbrellas, whatever. Until hats, etc. Then put sunscreen. That's one aspect. Second aspect is, these visible light, to be protected, you have to use tinted sunscreen, which is really little amount of sunscreens available. Tinted, you know what tinted means? It's like a color. أيوة نفس الشيء. It's a tint. Literally, you're painting your skin to protect against visible light. Okay? Alrighty, last question. Do dark skin, more towards black, need to put sunscreen?
Yes.
Melanocytes, origin, neural crest. Where is it located? Yeah, lobe meninges, eyes, inner ear, climactic. But the most important is the skin, eyes, and that's why when you do laser, we put special goggles because it will hit your iris and even into the retina and somewhat, but mainly the iris. Okay. A melanocyte is a cell that forms melanin. Melanin is your color. Why your color, your shade is different than the one beside you is because it's your genetic that tells you I need this amount of melanin. Become darker, more melanin. Become less darker, bleaching agents. Melanocytes are equal with everyone. But the melanin is the difference. When you have abnormal number of melanocytes, you have abnormal level. Albinism is the opposite. You don't have it. You have melanoma. It's cancer. When you have a lot of cells, I mean, if it's malignant, but if it's benign, what do you have? Close. Mold. Tamam? Excellent. The word nevi means زي الهمرتوما. Normal cell and abnormal location and collection. Okay? So it could be vascular, we call it nevus flammeus, sebaceous, nevus sebaceous, melanocytes, melanocytic nevi. So first type of melanocytic nevi are called congenital melanocytic nevi. Those are the ones you're born with. Okay? Could be a dot, and they could be all your back. The problem is, the bigger it is, the higher risk you develop cancer in it. Smaller it is, the normal and it's safe, it's fine. When someone says shama and dushama, how do you almost, it's always a melanocytic nevi. One important thing about melanocytic congenital melanocytic nevi, they break the rule of melanoma. What's the ABCDE rule? Asymmetry B, C, D, diameter, E, evolution. So هذا يقول shama. In Arabic we say shama. Okay, when we see someone having like this hairy stuff, And when it's huge, it becomes, as you can see, like a werewolf. The size divides them, and we divide them because of prognostic outcomes. Small, as you saw, this small ones. Medium is in between, and you see the range. Look at it. Less than 1.5, the 1.5 to 20 is medium, above 20, and then giant. Giant is literally like wearing something. Okay? And this is what we see in the clinic. Okay? Family happy with their new kid. Boom, he has a huge spot. They're devastated. And it breaks all melanoma rows. As you can see, except bleeding with ulceration or forming tumors. That, you should rule out melanoma in it. Okay? Another issue is congenital melanocytic nevi could be in a syndrome. What is this called? Neurocutaneous melanosis. Neurocutaneous. Didn't we say it's in the leptomeninges at the beginning? So they can develop melanocytic nevi, the giant ones, in the brain. And what sucks is there's no treatment. And I've seen 2 kids die from this. They just die in front of you. They sees blood all over, pressure, acts like a malignancy. Okay? So what makes a melanocytic nevi, the congenital ones, risk for developing this syndrome? 3 things that you need to know. 1, the red stuff. Giant. 2, what does axial mean? In the middle. 3, satellites. When you have a big one and you have small ones around it. So these are the 3 risk factors. Okay? This is a typical kid that comes to you in the clinic. And they're seeking treatment. So this is what we were talking about melanoma risk. It increases with the size. The larger, the more melanoma. What we do, if it's small contained, we tell them, live with it. This is you, your signature, etc. Or we laser it off. We literally scar the area. Scar looks better than the mole, okay? The other option is serial excision. What is this? This thing on the top. That pump thing. You guys know what it is? Do you see here in her head? This is inside. Why do you think we're doing that? So when you get fat and you lose weight, your skin flops, right? So we're inducing that. So we're stretching the skin. Exactly. Then you flip the skin and cover the excised area. And it ends up being a scar. You can see scars of surgeries like these end up being irregular. So that was the congenital. Any question on congenital? Good. So acquired, who has a mole? Almost everyone, right? You should have a mole. So the other question, can you get a mole when you're older? Is it normal? Okay. That's important, okay? You can get it, but I would be more cautious. If you're older and you get a mole and it looks weird, my threshold to investigate melanoma is much lower. Because most of your moles happen when you're a kid. Literally, they think that when you start going out in the sun, your moles start to activate. Okay? But the more sun you get, the more you get. The other people who get moles, suddenly that takes some medications, chemotherapy, phototherapy, and transplant. These people come in, suddenly they have new moles. So that's not unexpected. We divide moles based on pathologically where they are. Could be junctional, compound, or dermal. And they actually look different. So this is where pathologically they I mean, see where they're located? They could be in the junction, could be junction plus dermis, and it could be all the way in the dermis, okay? One thing, do you guys know what Tyndall effect means? It's a scientific term. Why is the sky blue? Yeah, but you know that it's not supposed to be only blue, right? Because the blue light is the only one that reflects to your eye. Okay. So when you look at a mole, the higher it is in the skin, the more black it is. The deeper it is, the lighter and blue it is. Okay, so black, brown, brown, tan, brown, blue. This is how we see it. Okay. So again, going back to your ABCDE thing, so moles, to be good, they should be not more than 1 centimeter. 2, color is good. It's almost the same color, or exactly you can say this is brown, black, not brown, black, red, black, gray, black, whatever. Borders, you can easily draw and it's smooth and nice. And it's regular, okay? And symmetrical. So put a line, this side looks like this side, okay? Asymptomatic, and not bleeding, not ulcerating, etc. And appears early in life. So these are examples of your typical moles that everyone gets. With time, the ones, as you can see in this lady, you can lose the pigment and become skin colored. Because the melanocyte is just old, stops producing melanin. Okay? What's this? Yeah, it's called dermamelanocytosis. It's true. But do you know what we used to call it? Yeah, this is Mongolian patch. We stopped saying it because I think they want to be politically correct and what all. But the problem here is because it's not only Mongolians that get it. Actually, if you have a brother or sister, newborn, just look at their butt and back. You'll see this. Almost 90% of them have this. Okay, so it's very, very common, especially in Asians. Not Asians, Chinese, all Asians. Okay? And what color is it? Where do you expect the melanocytes to be? Deep. That's why it's called dermal melanocytosis. Okay? If you take this, some people are born with it right here. And that's called of OTA. I just lasered someone with this. It works, laser works beautiful. It almost normalizes the pigment. The issue with this, it could involve the eye. As you can see inside the sclera right there, it's blue. You cannot remove this. Why? Yeah, didn't I tell you before the laser we wear goggles? Because when you hit it, it's not going to go only over there. It's going to be sucked by the iris. You're going to damage. Second thing is sometimes it clumps and increases the eye pressure and causes glaucoma. And because it's a melanocytic collection, there's a risk of, so you can get uveal melanoma, okay? Laser is excellent, very good. So you have acquired melanocytic nevi and you have melanoma. And between them is this dysplastic nevus. I cannot emphasize how much I hate this because we used to have a lot of, I mean, here in our population, Middle Eastern, South Indian, African, etc., it's not a big issue. But go to the Caucasians. They're obsessed about their skin. They're always afraid about their skin because they get melanoma. Who went to Australia before? Anyone went to Australia? No? If you go to Australia, the government gives you free sunscreen. I mean, there's theories, I don't want to be political here, but some people say because they're living in an abnormal place where the sun UV is very high in a population that's not supposed to be there. That makes sense? Yani, I mean, I'm not supposed to be there, not from, I don't care about the political point of view. I mean, from a genetic and evolutionary point of view. Africans are in Africa, they adapt. Arabs are, or Middle Easterns are in Middle East because they adapt. Chinese are in China, Indians are in India, etc. They adapt because generations, your mutations of who's before you, right? So you adapt better and better. So if you take a population, throw them somewhere wrong, you might expect abnormal things to happen. So one of them, that's one theory, okay? The other theory is they're just genetically susceptible, okay? But their numbers are extremely high. It's actually the number one melanoma in the world. Yeah, and I mean, we can argue. They love surfing, so that's another thing, and they're very bad with sun. Like they love the sun. Anyhow, so dysplastic nevus, it's a melanoma سياحي السيارة مو full option سياحي هذه أسوح من السياحي اللي يعني you buy diesel manual and it still did not push to become a melanoma. But I would argue with this, it's a headache. You take it, dysplastic nevus, what does that mean? Is this a melanoma or not? Second thing, should I remove it or leave it? So we always remove it, okay? And this is one lesion that a dysplastic. See, it's misbehaving. The color is a bit different, but it's not strikingly bad. Symmetry is not the best, but not strikingly bad. It's not that big. See if you see the measure, it's not that big. Still, it's not normal. So this is a gray area. The problem happens with this. So this syndrome is called dysplastic nevus syndrome. Some people have, especially that they're orange heads, quote unquote, ginger. Okay, those are very high risk of this. And they come to you as like, I want to check my moles. Okay, think it's fun? They take off their clothes. They have like 300 of these, or 400, even sometimes. Yeah, so much that's so hard to track. In Germany, I just recently went there. They have an amazing device because they're Caucasian, right? They're worried about their skin. So AI is very helpful for this. So what they have, it's a crazy machine. You go inside and stand. And it's like cameras and it moves around and it does 3D printing. So what it does, it scans each cell, each melanoma, sorry, each nevus you have, all over, takes pictures of them and it grafts it in a diagram and it tells you the ones that might be risky. And that is in the database. So when you come back next time, you go in, you compare to what you had. So it's so smart. Yani it just tells you, oh, this grew like 6 millimeter. So that's how much it's smart, but it was super expensive. So it was like something kid, very big and fancy. So you can imagine how much helpful it is for these people. Because it's so hard to examine. You even look between their toes. I had someone who had the melanoma just between his toes. He didn't even notice. So it sucks to have that much moles, okay? The mutation is CDKN2A. And it has been associated familial risk of pancreatic cancer. CDKN2A is a mutation in a lot of cancers, okay? But this is a syndrome. It's an autosomal dominant. The risk of melanoma in these people is 100%. They're going to get it sooner or later. Management. Just have to check on them very frequently, 6 months. Excise what you think is abnormal, okay? And just screen. Keep screening them. Luckily, we don't have people like this. This lesion. Good, bad. Why? Good. The different colors, asymmetric, borders are bad, and size is pretty big. So this is melanoma. So there, I think there's a typo. It's 75% de novo. What does de novo mean? By itself, yani. Yeah, nothing preceded it. Yani. New mutation. New, okay? So the majority come without a precursor. Yani, melanoma, you get a weird thing, it's melanoma, the majority. But there is, yani, quarter to 1/3, I would say quarter or less actually, happen from precursors. What are the precursors we talked about? Dysplastic nevus, acquired nevus, congenital melanocytic nevus, nevus of Ota, okay? Those are the things that could come from. So the de novo ones, the main ones in situ, when we say in situ, again, it's upgrade from the dysplastic, but a downgrade from pure invasive melanoma. Okay? The other types, which one is the most common? Because you read your book, who's the author? It's probably a North American Caucasian author. When you read it, that's in Caucasians, type 1 and type 2 skin, okay? But if we make our own book, which one would we say is most common? Actually, the majority of melanomas I have in King Faisal are, which one do you guys think? No, acral lentiginous melanoma. acral يعني acral اللي هو hands and feet peripheral. Lentiginous, it looks like lentigen. Melanoma. And the other ones we talked about. See this statistics? Caucasians. The statistics we have much less melanoma. But the most common one that happens in dark skin is acral lentiginous melanoma. Who's famous and died from it? Reggae. Bob Marley. He died from acral lentiginous melanoma. Okay. What's wrong with this? Yeah, what we're trying to show you is symmetry here. Okay. What about here? Color see how it's red, blue. You know what did I just tell you about Tyndall effect? That means some of it is up, some of it is down, some of it is lower. Yeah, that's not how it should behave. It should be in a basket together. Once it's spread, it's just tell you it's not. See these? They're ugly. You see it on the skin, it's ugly. There's another subtype that they didn't mention. Do you know that there is something called amelanotic melanoma? Amelanotic melanoma. It's red, has no pigment. It's very, very hard to detect, okay? When we look at dermoscopy, our scope, this is what we see. See the levels, the color difference is because of the levels. And each one indicates, you don't need to worry about it. Risk factors. Dysplastic nevus, family history of melanoma, type 1 and type 2. Who knows skin types? I'm going to run through it very fast. Skin type 1, always burns, never tans. Skin type 2, almost always burns, occasionally tans. Skin type 3 and 4 are us. 3 sometimes, or actually burns occasionally, but tans regularly. Skin type 4, yani the difference between 3 and 4 is tanning and burning. More tanning, but less burning in 4. 5 and 6 is based on color. They say yani dark skin. 6 is very dark skin. Yani they say black or yani brown black, then black. Okay?
So it's basically as you go down, less likely to burn, more likely
Exactly.
to get
But where's the problem here? It's not true. From 1 to 4, I think is a reasonable division. 5 and 6, I don't think it's a reasonable division. Because there are black skin that burn. So why are you dividing 1 to 4 through behavior and 5 and 6 through color? It's stupid, I'll tell you. But 1 to 4 is the more important one. Because the majority of dark skin or black skin, they do not burn, the majority. But doesn't mean they can't, okay? So risk factors, again, light skin and Caucasians, هذول in easy terms. Type 1 is redhead. Ed Sheeran-like look. Type 2, most North Americans, Europeans. Type 3, fair Middle Easterns. Type 4, the majority. But in 3 or 4, the majority of us. 5, خلاص, you go into more African, either African or African American, whatever. Number of moles, the more you have, the more risk you have. Syndromes, which had mutation, CDKN2A, immune suppression, anyone who's taken transplant medication, blah, blah, all that, because your body is not able to take away the mutations or damages that happen. And one of the most common risk factors is blister burns when you're a child. Burns that blister when you're a child. Okay, but it's usually in Caucasian, not us. So again, in side 2, what does that mean? Exactly. So it's not invasive. It doesn't pass the basic membrane. So that's the nice one. Because the difference between these is margins. When you want to exercise, you have to take, it depends on the vertical growth, different characteristics. This is the one that we said the most common and more type 1 and type 2 skin. And this superficial spreading malignant melanoma. Nodular is just, it's a huge piece. Usually it bleeds and ulcerates and all that. This is the one I told you, the acrylentigenous. Most common in dark skin individuals. Okay? And when you have a mole on your nail, it's normal, it's a line. But when it's bad, you'll see it crossing. Number 2, it's more than 3 millimeters. Number 3, the color is variable. Number 4, this is a good shape, but usually it's abnormal shape. Okay? This is ontygomaligna melanoma. This is another one that could happen. Okay, you get like a lentigen. It's like a patch. Honestly, they all look weird and abnormal. As you can see, this one, if you see this on someone's face, you definitely need to biopsy this. Okay. See, there's a nodular melanoma here with abnormal. See how it's very asymmetrical. Normal skin, then abnormal skin, then white, then gray, then black, then red. Just tells you how bad it is, okay? The other thing that is, because mucous membranes have melanocytes, you can have melanoma in your glabrous skin, oral, eye, ear, genital. So prognostic factors, it's better in females than males. Location, it's better in extremities than in the axial. The other stuff you don't need to worry about. So what you need to do is detect and remove. Detect by suspicious lesions, take a biopsy. Never shave a melanoma. Never shave a pigmented lesion, because if you shave it, you ruin the staging. Staging is by vertical growth. So if you shave it off, you don't know what's below it. So always biopsy it. Either remove it or take a punch biopsy. So could metastasize, the most common place to metastasize is the lymph node. Where could it go? Everywhere. Okay? Now, with more, usually the advanced ones, so I'll give you the simple way of looking at it. Simple ones, we cut them off. Done. Screen you every once in a while. Worse ones, we cut them off and check your lymph nodes. And if the lymph nodes are involved, we have to cut them off, possible radiation, chemo, etc. More than one organ, extensive, you have to give systemic therapy. I didn't say chemotherapy. What did I say? Systemic therapy. The reason is now we have some new stuff called targeted therapies. You guys know what RAF, RAS, MIC, ERK pathway? Cellular pathways, right? Just like PIK3CA, mTOR, all that stuff. So these tumors have these mutations. So when you inhibit them or block those mutations, you block the tumor. So RAF, MIC, you have to get molecular first from the tumor. If it's positive in the majority of the tumor, then it will be a good agent to give. The problem is how nasty tumors are. You block this, they look for an alternative pathway. And that's why sometimes it recurs. Okay? The second type of therapy, do you guys know program death ligand and program death receptor? Have you heard of those before? No, fast ligand, yes, that's one of them. But PD1, PD, have you heard of this? I'll just make it simple. You have tissue. I raise a flag, program death ligand. It's on a lymphocyte. Lymphocyte comes, once it attack me, I poke it with it, it dies. So these tumors are nasty that they do that. So they stop your lymphocytes to attack them. So what you do with this is you go inhibit this ligand. So imagine when you inhibit the ligand, what happens? It starts attacking, right? What's the downside? Sorry? Yeah, you said autoimmune? Yes, because drugs are not very smart. They go by receptor, blah, 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 whatever. But you'll get itis in a lot of places. You can get all over. You can get dermatomyositis, lupus, psoriasis, eczema, vitiligo, yeah, and different more pneumonitis, myocarditis. So the ones pembrolizumab, ipilimumab, and nivolumab, you can see those in different cancers, not only in melanoma, lung, genitourinary, etc. And this is the pathways we were talking about. You see a lot of blocking that's happening with different pathways. The more we know, the more we're targeted. So just want to end up with one fast story. Can we stop recording?